evening, or good afternoon, or good morning, everyone, wherever you are. Welcome to our meeting. First of all, I'd like to thank EPCO for making this meeting feasible, and also would like to greet moderators and my colleagues. And let's start today with the preoperative evaluation for cataract surgery. So let me show you some fundamental knowledge about the preoperative assessment for patients who is going to have cataract surgery. Our talk today will be in these four sections. We will first have some brief overview about the classification of cataract. Then we will go through the history taking, then some important tips during ophthalmic examination for patients who are undergoing cataract surgery, and finally the screening of high-risk patients that you need to know and you need to identify so that they could have some certain risks during the surgery. First of all, the classification of cataract is so you know that the cataract can be classified according to morphology or according to the maturity, or also we have the grading of cataract. So we know that the anterior polar cataract is like a small opacity in the anterior lens capsule that is usually visually insignificant. Usually it is bilateral and symmetrical and usually doesn't progress over time. This is on contrary to the posterior polar cataract, and the posterior polar cataract is present beneath the posterior capsule, but it tended to be more visually significant, tended to increase over time. It tends to increase over time, and it poses a certain risk during surgery, especially during hydrodissection, where it could lead to capsular block syndrome, and consequently rupture of posterior capsule. Also, we have the cortical cataract. In the cortical cataract, it is present with opacification of lens cortex, and in lens cortex will present with wedge-shaped opacities. Usually it's white-shaped opacification, which is present, as you can see here, in the direct illumination or in the retroillumination. The nuclear cataract is one of the most common types of cataract, which is present with yellowish discoloration of the lens, as you can see here, due to the unichrome pigment. It is usually affecting the nucleus more than the cortex, and when it is increasing in density, it will give rise to the brunescent cataract. Posterior subcapsular cataract, it is present with these granular or crystalline-like opacities present just beneath the posterior capsule. This is how it looks like in the direct illumination, and this is how it looks like in the retroillumination. And usually it can be idiopathic or can be due to chronic steroid use. That's why you should inquire about the long-term use of steroids. It can also be due to radiation, or it can be due to a sequelae of some surgeries such as parsoplanary vitrectomy with silicone oil implantation. The end stage of subtotal cataract will be a diffuse or total cataract, so this will be characterized by total opacification of the lens, and not only it can be due to a progression of nuclear or cortical cataract, but it can also be due to a sudden incident like trauma. As you can see here in this picture, you can see that there is some evidence of trauma, as you can see the rupture of the sphincter pupil, and here is the field of hypottic capsule, and there is total opacification of the lens. And of course, there is traumatic mydriasis. According to maturity, the cataract can be classified into immature cataract, where it cannot be visually, it is not very visually significant, and then it can progress to mature cataract, where there is total opacification of the lens, and when the lens is swollen, it is called intumescent cataract, and this can give rise to phacoemulsification glaucoma, so this should be looked carefully before the surgery. And we have the hypermature cataract, where there is total opacification with fibrosis of the capsule and shrinking of the lens, which can be also present in the Morganian type, where the cortex is liquefied and the nucleus is sunken down in the loose bag. Grading of the cataract is also very important to address before the surgery. As you know, there is different systems that grades the cataract, like the lens opacities classification system 3 or Lucas 3. There were 1 and 2 before, which classify the cataract according to the size and density and location of the opacity. Mainly it is concerned with the three main types of cataract, like nuclear cataract, like cortical, and posterior subcapsular cataract. So you can find in, there is some lag in the presentation. Can we return back to the previous slide, please? No, it's a preoperative evaluation for cataract surgery. Choose the self-extractable one. Preoperative evaluation.
Classification of cataract.
Okay, thank you. You can find in this table the different kinds of cataract and what is the classification according to the site and density and location. Okay, so this is just a brief overview about the different types of cataract. So when you have a cataract patient, the first thing to do is history taking, and this is based on outpatient appointment. So there are some points that you need to address when you are considering a patient for cataract surgery. First of all, you should confirm that the diagnosis of visually significant cataract. Does the patient has a problem with vision due to the cataract, or it is attributed to another cause? Also, you have to ensure that the cataract is the cause of the visual symptoms. Also, regarding the cataract, you have to check the characters for cataract, as we mentioned. What is the morphology of the cataract, and what are the different functional aspects of the cataract. So you know that the visual requirements for patients are very variable. So you cannot compare a farmer, for example, to a computer engineer who have the same grade of cataract. Sometimes those who have low visual requirements will not complain in the early stage as same as those who have high visual requirements. Also, you should check that if there is any coexisting ocular pathology that will be more visually significant than the cataract. For example, if the patient has corneal opacity and the cataract is weathered, so you may consider whether to give them the chance of triple procedure, or if they should go for keratoplasty alone or cataract alone. Also, you should take into consideration the quality of life and that the cataract surgical extraction will give to the patient, and also if the patient wish to undergo surgery and understand the risk and benefits. So informed consent should be obtained from the patient, where he understands what is going on in the surgery. And eventually, after you fully take in history from the patient and examining him, you should formulate a surgical plan, and then you are now ready for the surgery. So let's start now with the history. So when you are taking history from the patient, what are the main points that you should inquire about? As any medical scenario, as we know, the first thing is to start with is the complaint. So you should analyze the patient complaint. As you know, that those patients will have a gradual progressive loss of vision. Usually this is the scenario. But sometimes will not be the case. For example, if the patient has undergone trauma, this will cause a sudden diminution of vision. Or if the patient has coexisting pathology, or if the patient is, so this is the complaint usually as it is gradual progressive loss of vision. It usually is painless. However, sometimes it can be painful if there is coexisting pathology like rise of intraocular pressure is in case of lens-induced glaucoma such as phacoemulsification or phacolytic glaucoma. Then this brings us to the past ophthalmic history. In the past ophthalmic history, we should inquire about many things. First of all, is there any trauma? Let me just tell you something that before we are proceeding to the future and we are going to give a patient a cataract surgery, please don't overlook the past. Because sometimes the past will give you a very good clue about the future. Let me give you an example. If the patient has undergone a cataract surgery for one eye and now is proceeding to the next eye, sometimes we may find an evidence of complications that happened in the first eye, and this can give you a clue that this complication might happen also in the next eye. So careful examination of the previous eye, careful inquiry about the history, like the trauma, like if there is any history of existing co-ocular disease like uveitis that can pose a certain risk of small myopic pupil or posterior. These are very important to address. Also, the past medical history is important, and you should know or you should inquire about the patient medical history, like, for example, like diabetes. As you know, the cataract surgery will worsen the diabetes. Lens extraction by itself can worsen the diabetic retinopathy, so we should address that in the start. Together with also hypertension, which may increase the risk of suprachoroidal hemorrhage, and other medical problems or like COPD or chronic progressive obstructive lung disease, which will make the patient orthopnic and unable to slide down. So this also you need to inquire about. The drug history also is very important. Like you need to ask about if the patient is on anticoagulant. You know that the cataract surgery is a bloodless surgery, so this is not a very major issue in our case. But what is very important in those patients are those who have benign prosthetic hyperplasia and they are on alpha blockers. Those who are on alpha blockers, like on Samsonine, they will have a problem intraoperatively called the IFIS, which is the intraoperative floppy iris syndrome, which will make the surgery very difficult. Then you should inquire about the allergy. If the patient has any history of allergy to any drugs, this will also be important. After taking good history from the patient, and then you should proceed to the ophthalmic examination. And in ophthalmic examination, we will follow a stepwise manner or a systematic approach in order to address all issues and all ocular structures that can be that should be examined carefully before proceeding to cataract surgery. First of all, we need to measure the visual acuity. It will be uncorrected and best corrected to know where we are standing now and what we aim for. For example, sometimes the patients will be amblyoptic, and this should be identified prior to the surgery, otherwise we will face a very frustrated patient. Then we should do accurate refraction. We should do know the patient's refraction, because sometimes some cataracts can produce a change in refraction, like in myopic shift that occurs in nuclear cataract. Also, patients with high myopia and high hyperopia will have a certain risk in the surgery. Then we should proceed to the pupil examination. And pupil examination, this will be your chance to examine the patient pupil before you dilate the patient in order to identify if the patient has any abnormal pupillary response, like relative atrial pupillary defect. So in that case, with a positive regurg test, and this also can be a risk for post-operative endophthalmitis. Conjunctival also should be examined for presence of acute conjunctivitis, and this also can be a risk for endophthalmitis, as well as for patients. You should also inspect the other eye. Sometimes you can find an inophthalmic socket, and this inophthalmic socket can present with infection, and again, this should be managed before the cataract surgery. Then you should have also inspected the orbit or should inspect the orbits. Sometimes you can find that the patient has atrophy of the orbital fat, and there is prominent supraorbital ridge and sunken eyes, which is sometimes making the surgical procedure more difficult, and this shouldn't be your first case to do. After external examination, you should go into the intraocular structures. So first of all, you inspect the cornea for presence of any corneal opacities, and with particular importance to the presence of luteins. Patients with presence of corneal luteins and diffuse endothelial dystrophy can have a certain risk of endothelial decompensation after the surgery. Anterior chamber also should be inspected for presence. Anterior chamber should be classically should be optically empty and with no cells and no flare in the anterior chamber. I guess that there are some cells in here. I don't know if you can see it or not. But this patient has uveitis, and this patient shouldn't be admitted for surgery all the way down, but they should be managed for treated for uveitis first. Iris also should be inspected for a very dangerous sign and very important sign that must not be missed, which is iris neovascularization. So this is a sign of severe ischemia. Lens should be inspected for the grading of cataract, as we said in the beginning of the lecture, and also for the presence of the pseudoexfoliation syndrome. Usually this is how it looks like after the pupil dilatation, but before dilatation it will be present with like a dandruff-like material over the pupillary edge, and this can sometimes be easily missed. Finally, the final structure that can be examined with the slit lamp without use of any auxiliary lenses, which will be the anterior hyaloid. I don't know if you can see that there are some cells here present in the anterior hyaloid as this patient has intermediate uveitis. Sometimes you can see some brown pigmented cells, which is called the Schaffer sign, which is present in cases of retinal detachment. Then you should use your auxiliary lens like the 9 diopter or 78 diopter or the indirect ophthalmoscopy in order to examine the posterior segment of the eye. So you can check for the vitreous, as sometimes the patient could have a vitreous hemorrhage, so the patient is attributing his loss of vision to the cataract. However, the loss of vision is due to vitreous hemorrhage. It is a very common scenario, especially in diabetic patients. Also, something that that you should counsel the patient about if they have posterior vitreous detachment. There is here like a vice ring. I don't know if you can see it or not. But sometimes these patients cannot appreciate the presence of floaters before the cataract surgery. But once the lens opacity is removed and now they are fully aware of the presence of floaters and they told you, okay doctor, you are the cause that give me these floaters. So please pay good attention to examining the vitreous for those patients. Sometimes when we don't have a very good fundus view, or at all times when we don't have a very good fundus view, we opt for ocular ultrasound in order to detect if there is any problem. Just for that, there is a fundus examination will can sometimes show presence of retinal detachment or presence of retinal break, or sometimes it can show the presence of optic atrophy, and this should be proper counseling with the patient should be done, as these patients will not unlikely to benefit from cataract surgery as they have optic atrophy. In case that you don't have a very good view for the fundus, you should order ocular ultrasound in order to detect if there is any retinal detachment or posterior segment pathology. That should be addressed as well, so that this patient will be managed by vitreoretinal surgery. After complete and the thorough examination, you should now proceed to the next step, which is biometry, as we will be fully explained by Dr. Hisham in the next lecture. So I will give this to him. And after you do the biometry, you should come up with a surgical plan. What is a surgical plan? A surgical plan should include the intraocular lens type and the power. You should know what kind of intraocular lens that you are using. Is it hydrophobic? Is it hydrophilic? Is it 3-piece or single-piece? And also know the power of this lens. Then you should identify what will be your incision site. Should you go for the temporal site, or at what location should you go for the incision? For example, you may go for temporal incision in case of a shallow orbit, or if there is a deeply sunken eye, that will make the classic location or classic site difficult. Also, you may consider opening on the steep meridian. So this should be noted before the surgery. Type of anesthesia also is important to note before the surgery. So if this patient is a candidate for topical or subteral anesthesia or peribulbar or retrobulbar, this should be also noted. And finally, you should note what are the specific risks. Sometimes the patient will have a specific situation or certain situation that makes the surgery difficult, and this is what will be addressed now in the final part of our lecture, which is some high-risk patients. Those patients, you don't need those patients to be your first patient. So if you are unexperienced cataract surgeon or you are still in the learning curve, please identify those patients in order to avoid that you can you provide the patient the best outcome. First of all, those who are using the alpha blocker like the tamsuline, and those can be present intraoperatively with a flared iris that keeps coming out from the main incision and side pores all the time, which making the surgery very difficult and with high risk of complications. Also, patients with high myopia and high hyperopia, and patients with difficult access, like for example, if the patient has, as you can see here, a sunken eye with a prominence of the aortic ridge, this can lead to distal detachment, this can lead to more risky surgery. So you will consider going with temporal incision and giving ample anesthesia. Those patients who have high myopia or high hyperopia, those also can have certain risk. Those who have high myopia could have high risk of retinal detachment with unstable anterior chamber. Hyperopic patients will have a shallow anterior chamber. Patients with corneal problems, especially if they have corneal opacity or fuchs endothelial dystrophy, should be managed carefully to avoid corneal decompensation. And finally, those patients who have small pupil should be also identified. Those who are difficult to dilate, those who need those who have posterior synechium, we should identify them in order to provide some pupil expanders, or we know what are the surgical plans that we will address this small pupil. Also, not to forget some certain kinds of cataract that are difficult to handle in the first or in the beginning of learning curve. Like for example, a very hard cataract, which is the end stage of nuclear cataract, which is called the brunescent cataract. This will be difficult to tackle in the beginning. It's very hard with high risk of rupture posterior capsule. Posterior polar cataract, as we said in the beginning, will also be a problematic cataract that needs to handle very carefully and to identify in order to avoid rupture posterior capsule, as these patients usually can have a defect in the posterior capsule. White cataract also will need specific precautions, especially if they are intumescent by aspiration of lens material and staining of the anterior capsule. So exfoliation also can be present with rhizonial and difficult dilatation of the pupil. So this also shouldn't be your first case. And finally, zonular dehiscence, which can be sometimes be congenital or due to trauma or due to pseudo-exfoliation. And again, this should be managed with a variety of methods like the capsule tension rings, ion ring, or ring segments. So this also shouldn't be your first early cases. So please identify these cases in your early cases so that you build up your experience in the proper way. Thank you very much. I hope that this lecture was helpful and handy, and I will leave the mic to Dr.